All right, so this final lecture is on the brain. So let's take a look at some of the key concepts here. Now, embryologically, when we look at the brain and the neural system in its whole, the brain and spinal cord, the evidence of the neural system shows at around day 18 or so. After the sperm and egg unite and fertilization takes place, and the baby within the mother's womb starts to blossom, the very, very first thing that develops is the neural system. But before it's the neural system, it's actually referred to as a primitive streak that becomes the notochord. And the notochord ends up becoming the brain and the spinal cord. There's no heart, there's no lungs, there's no bones yet. The very, very first thing that develops is the nervous system or the neural system. And one of the things that I want you to look at is over here, you will see the main, on the left, you see it's kind of like embryologically, we have these main vessels like the proencephalon, the metencephalon, and rhomencephalon. And then over time, they kind of evolve into the telencephalon, diencephalon. So I'm not really going to hold you accountable for this, but the main parts of the brain, absolutely. We'll be talking about the cerebrum, the thalamus, the hypothalamus, the midbrain, the pons, the cerebellum, the medulla. We'll be talking about the lateral ventricles, which are two. You'll see that there's one in each hemisphere. So there is two lateral ventricles, lateral ventricle 1 and lateral ventricle 2. And then the cerebral spinal fluid flows into the third ventricle through the cerebral aqueduct of Sylvius into eventually the fourth ventricle. So these are the main parts of the brain that we'll be discussing, some structure and function. When we look at a cross section of the brain, right, this is a sagittal view. So we're looking at the left hemisphere here. This is the cerebrum. This is the largest part of the brain here. The diencephalon is this center part. And when you see the diencephalon, it is made up of, anytime you hear the word thalamus, there's thalamus, hypothalamus, epithalamus. Those are all part of the diencephalon. Then we have the brain stem, which is composed of these three parts. From inferior to superior, we have the medulla, the pons, and the midbrain. And then on the posterior part of the brain stem is the cerebellum. And we'll go into quite a bit of detail in all of these parts. I'm not going to click on these links, but you have these interactive links that when we're done, you can go back into the PowerPoint and click on them to review them on your own time. So again, here is the cerebellum. Here is the thalamus. Below it is the hypothalamus. Then we have the midbrain, the pons, the medulla. Below the medulla is the spinal cord. Posterior to the midbrain is the cerebellum. We'll talk about the cerebrum and the different lobes of the cerebrum. There happens to be an anterior lobe, an occipital lobe, a parietal lobe, and a temporal lobe as well. The brain is a pretty large organ, weighs about 3 pounds. And the brain serves many different functions, sensations. It's a main processor of information. It's involved in memory, your emotions, your decision-making, your behavior. So for example, if we were to look at the frontal lobe of the brain, the frontal lobe is designed to inhibit activity, meaning Um, let's say a little boy wants to push his little brother down the stairs because one took the other toy, right? Their frontal lobe really isn't developed in young children, so they act impulsively and they just push one child and they can fall down the stairs. And then the parent may say, "Hey, little Johnny, don't push your brother or sister down the stairs anymore. You shouldn't do that. Do you understand?" And the child says, "Okay, okay, mommy, okay, daddy." But then the very next day, they do the same thing. Now, why is that? The child understood at that moment that they shouldn't push them down, but the frontal lobe, the ability to inhibit behavior just isn't fully developed. Be honest with you, it's not even fully developed in many adults. We see many adults that do not have the ability to inhibit their actions, inhibit things they may say, so they act impulsively. You have many behavioral issues where people just act out and they don't have the ability to quiet themselves to say, if I do this or say this, this is really going to harm me in the long run. They don't have the inhibitory center. The frontal lobe is involved with your behavior, your decision making, with executive decision making. If I do this, what is the consequence of that? The frontal lobe has a lot to do with your ambition, with your drive. That is all frontal lobe controlled. If we look at a baby or an infant, you'll notice that their heart rate is very fast. Well, it's the frontal lobe that has to mature to inhibit and slow down the pace of that rapid heart rate. So as the child gets older, the heart rate slows down. The little baby is wearing a diaper because they can't inhibit when they go to the bathroom. They're going to urinate and have bowel movements in the diaper. It's only until they get 4 years old, right, 3.5, 4, the frontal lobe starts to develop more. Then they can inhibit because they know, ooh, they feel the sense of urgency that they have to go to the bathroom. Mommy, daddy, I have to go to the bathroom, and they go. This is also holds true as the mature brain develops, but then as the person becomes older and older and older, maybe 90s, 100s, the frontal lobe can start to degenerate and deteriorate again. And when that happens, then we have these senior citizens going back into the diaper, right? Because they can't inhibit or control running to the bathroom. When there's brain damage, people have to wear diapers at times. So the frontal lobe is very, very important in terms of your ambition, your drive, right? The one kid that wants to leave home at 16, 17 years old, take on the world, very ambitious, has dreams, goals, and accomplishes them all. Very healthy frontal lobe. Then there's the frontal lobe that isn't functional or as functional. And this is the adult child that stays at home till they're 40, 50 years of age, and they live in a basement. They don't have the ability to self motivate and accomplish and to move on. They get very comfortable and complacent and they just stay. So, frontal lobe is a very, very important part of the brain. The occipital lobe back here is where your visual center is, very important for vision. Your parietal lobe is more about perception, your perception about your body and all the parts of your body and where they are in space and time. That's more parietal lobe. Your cerebellum back here is balance and coordination, being able to take your finger and touch it to the tip of your nose with your eyes closed. When I tested one of my patients on this the other day and I said, close your eyes and touch your pointer finger to your nose, it looked like this, like that. That's a cerebellar problem. It's a cerebellar lesion. We'll talk about the medulla, the pons, and the midbrain in a little bit more detail. I just wanted to touch upon some of the main parts of the cerebrum to whet your appetite for today's lecture. So when we look at the brain from the lateral perspective, we have to be able to differentiate anterior from posterior. So the cerebellum back here is always posterior. So this is the front, this is the back. So this is occipital lobe, this is frontal lobe. On the side, we have the parietal lobe. Now the frontal lobe goes from the front all the way right to the central sulcus. So here is the central sulcus. The central sulcus anterior to it is all frontal lobe, and posterior to it is parietal lobe. Okay, so this is parietal lobe here, and way, way in the back, that's the occipital lobe. And you should remember from lab the importance of the central sulcus, because what's in front of it is the precentral gyrus, and what's behind it is the postcentral gyrus. Precentral gyrus is your primary motor strip. It's where all your motor activity is initiated. And then the postcentral gyrus is where all of your sensory input actually ends up. Here's your temporal lobe, which is for hearing. The hearing center is here. There's your cerebellum for fine coordination. So your precentral gyrus is really responsible for initiating movement. So let's say I want to throw a baseball to someone. That precentral gyrus has to initiate that. But there's a photocopy message that goes to the cerebellum. And the cerebellum says, okay, we're going to coordinate that to make sure the ball doesn't go over the person's head. Okay. So the cerebellum gets a copy of that message and helps to really refine it and make sure that that motor skill is smooth, so that when a person is asked to touch the tip of the nose, it's smooth and not stop, go, stop, go, stop, go, stop, go, stop, go, and very shaky. That's a cerebellum lesion. Okay, so again, the main parts of the brain that we'll be talking about is the cerebrum, the diencephalon that's made up of the thalamus, the hypothalamus. Don't confuse cerebrum with cerebellum. This is the cerebrum. Back here is the cerebellum. Believe it or not, the cerebellum is known as the little brain. It actually has more neurons than all of this combined. That's how important the cerebellum is. So cerebrum, that's your frontal lobe, temporal lobe, parietal lobe, and occipital lobe. Your cerebellum is back here. So there is a right and left cerebral hemisphere, and then there's a right and left cerebellar hemisphere. The diencephalon, that's thalamus, hypothalamus, epithalamus, anything with thalamus in it. And we'll also find the pineal gland in there as well, which is right back here. Don't confuse the pineal with the pituitary. They are neurological, but also part of the endocrine system as well. Then the brainstem from inferior to superior, it's the medulla, the pons, and then the midbrain. So what do we have that protects the brain? What protects the brain is the skull. We have bone. We have the three meninges, which is the pia mater, the arachnoid mater, and the dura mater. The innermost layer is the pia, the middle layer, arachnoid, it means spider web, right? That's the arachnoid. And dura mater means tough mother. So we have the meninges, we have the vertebrae, we have bones, we have the skull, bone, and we have fluid. The fluid is CSF, cerebral spinal fluid. This is a really nice picture because it shows the chambers right here in the center where cerebral spinal fluid flows. So you can see the lateral ventricle here. We have one lateral ventricle on this hemisphere. We have another lateral ventricle on this hemisphere. So there's two ventricles. Then the cerebral spinal fluid flows down into the third ventricle. Then it flows down further into the fourth ventricle. And after the fourth ventricle, it exits right down the central canal. And if you remember the cross section of the spinal cord where the butterfly is, or the letter H, right in the center is that central canal. It's that pinhole. And that's where CSF flows. We'll talk a little bit more about the CSF in just a few minutes. Here we see the choroid plexus. The choroid plexus is found in the ventricles, and it's responsible for producing CSF. And it's lined with a type of neuroglial cell called ependymal cells, right? If you go back to that first lecture on neurology, we talked about the neuron, and then we talked about neuroglial cells. That's somewhere in the CNS and somewhere in the PNS. That's we talk about the astrocytes, the oligodendrocytes, the Schwann cells, the ependymal cells. So you may want to review those. Okay, the blood flow to the brain is off of the heart, and next term in Bio 204, when we cover the heart and all of the circulatory vessels, we'll see that we have a main branch, or the arch of the aorta, that comes off the heart. And then off of some of those main blood vessels, we have the vertebral artery that goes up through the transverse foramen of the cervical vertebrae. And then we have the internal carotid that comes into the brain. So both the vertebral artery and the internal carotid artery are so extremely important in bringing blood, sugar, and vital nutrients into the brain to keep it functioning. It's so important that the body's innate intelligence gives two highways of communication of delivering blood and glucose and nutrients into the brain. Not just the vertebral artery, but the internal carotid artery. So if there happens to be a traffic jam or a blockage in a vertebral artery, we could still get blood coming in through the other main artery, the internal carotid, or vice versa. If the carotid is blocked or clogged, we could still get blood through the vertebral. So the blood supply that gets into the brain is referred to eventually, when it gets into the brain, it's called the circle of Willis, because it actually does make a complete circle in the center of the brain, and it has many, many branches coming off of it. So the brain utilizes about 20% of the body's oxygen supply, and any interruption of the oxygen supply can result in dysfunction. Depending on what part of the brain that blood vessel is delivering oxygen and glucose to, if it happens to be the left part of the brain, where the Broca's area is that controls speech, now there could be damage to my ability to communicate. So if there's glucose deficiency, there's going to be confusion. There could be dizziness, convulsions. They can go unconscious. So if there's decreased blood and oxygen to the brain for more than 4 minutes, there could be some serious damage. When it's decreased for a prolonged period of time, we call it a stroke. And a stroke comes in two different types. There could be a blood vessel that ruptures. They call that a hemorrhage. If you have a broken or hemorrhaged or dissected blood vessel that's going to the brain, then you're going to have lack of oxygen there. What if there's a blood clot? There could be coagulation, there could be a thrombosis or a blood clot in one of those arteries, depriving glucose and sugar and oxygen to the brain. That's called a clotting or an obstruction type of stroke. When there is a stroke that's minimal, 2 minutes, 3 minutes, at least under 4 minutes, it's not really classified as a full blown out stroke. They call it a TIA. TIA stands for transient ischemic attack. Ischemia means lack of blood flow and lack of oxygen. That's ischemia. So it's a transient ischemic attack, transient, short term. Here we can see in this picture, we have two vertebral arteries. You see vertebral. Here's one vertebral. Here's the other. It becomes the basilar artery. The basilar artery right here goes through the magnum foramen at the base of the skull. And we can see the circle right here. Here's the circle of Willis. And off of the circle, we have blood vessels that go anterior, blood vessels that go lateral, blood vessels that go posterior, and they bring oxygen to all of the main centers of the brain. And when there is decreased blood supply to the medulla, there's a way of testing that. When there's decreased blood supply to the brain, to the pons or the midbrain, there's ways of testing that as well. That's why we have cranial nerves. The cranial nerves originate off of the cranium, off of the brain. When we get into cranial nerves, it's important to know that cranial nerves 8, 9, 10, 11, and 12 come off of the medulla. So we can test dysfunction to the medulla by finding any type of abnormality to cranial nerve 8, 9, 10, 11, or 12. When we look up at the pons, here in the pons is cranial nerve 5, 6, and 7. And in the midbrain, cranial nerves 3 and 4. And in the cerebrum, cranial nerve 1 and 2. And this is not just how to assess stroke. This is brain trauma. This is TBI, traumatic brain injury. This is concussion. So in my office, I'm often assessing people's brain function by doing a lot of cranial nerve testing and functional testing to see if there was a concussion, what part of the brain may be affected, and how can we retrain that individual and reactivate and keep that part of the brain more alive that may have been affected adversely. So the blood-brain barrier, we know that there's the blood-brain barrier protects the brain cells from harmful substances and pathogens and microbes by serving as this protective and very selective barrier that can prevent the passage of substances that are going from the blood into the brain. But the blood-brain barrier can also prevent the entry of therapeutic drugs. Injury to the brain can also cause the breakdown of that blood-brain barrier that permits the passage of what is typically normally restricted, and now it allows those substances into the brain. It creates a leaky brain, which becomes problematic. This is a nice picture of the brain from the lateral view, and the blue structure in the center right here, that is the ventricles. And remember, the ventricles is the are the chambers. That's what ventricle means. It really means chamber. It's the chamber for which cerebral spinal fluid is going to travel. So CSF is the liquid that protects the brain and the spinal cord against chemical and physical injuries, and it's carrying oxygen, glucose, and other nutrients that are important for the functioning of the neural system. So here in both hemispheres, we can see the lateral ventricles. Here, so that's lateral ventricle 1 and 2. Here's the third ventricle. Well, how does the fluid get from the lateral ventricles into the third ventricle? It's got to go through this chamber right here, this duct work, this drain called the interventricular foramen of Monroe. It's called the interventricular foramen of Monroe. Now it drains into the third ventricle. And now the third ventricle drains the CSF through the cerebral aqueduct of Sylvia, or cerebral aqueduct of Sylvius. And now it goes from the third ventricle into the fourth ventricle, which is just adjacent to the cerebellum. After the CSF is in the fourth ventricle, it can exit via the median aperture or the lateral aperture. And now we have CSF flowing up and around the brain and all throughout the spinal cord. The CSF, we have about 3 to 5 ounces of it, or 80 to 150 milliliters. It's this clear liquid that has glucose, proteins, ions, and as the slide before mentioned, it serves mechanical protection, chemical protection, and it has circulatory benefits because it brings nutrients to the brain and clears out waste products from it. Here again is another nice view of the ventricles. Here you could see the two lateral ventricles. Here's the third ventricle. And in order for the CSF to go from the first and second into the third, it has to drain through the interventricular foramen of Monroe. Now it's in the third ventricle. To go from 3 to 4, it has to pass through the cerebral aqueduct of Sylvia or Sylvis. Then it drains into the fourth ventricle, which is adjacent to the cerebellum. And we have the lateral aperture, which is an escape route, as well as the median aperture. Those are the two ways the CSF can leave from the fourth ventricle. And then it bathes and circulates all the way down the central canal, which, if you remember the spinal cord, the butterfly in the middle, right, where that gray connoisseur is, there's that center canal or central canal. The choroid plexus is it's a little capillary system that's covered by ependymal cells. And those ependymal cells are responsible for producing cerebral spinal fluid. This is just another view, but now we're looking at the brain from a different perspective. It's kind of looking at it from underneath. So you can see in each hemisphere, there's one ventricle, lateral ventricle 1 and 2. We could see the third ventricle and the fourth, and in the center, the median aperture, and then the lateral aperture. This is the cerebral aqueduct of Sylvius. And then right up here is the Monroe, the foramen of Monroe. And again, on the right-hand side, it shows you that flow from the lateral ventricles into the third ventricle through the interventricular foramen of Monroe, from the third into the fourth ventricle through the cerebral aqueduct of Sylvia. Then from the fourth ventricle, it goes in the lateral and median aperture into the subarachnoid space. And the subarachnoid space, as we can see, going around the entire spinal cord, and it pumps it right back up to the brain. So it kind of cushions and buoys the entire neural system from mechanical harm, gives it a nice protection. Right up here in the top, we can see that we have the arachnoid villi, which is a cluster of filtration capillaries. So the cerebral spinal fluid is filtered and reabsorbed by the arachnoid villi. If the arachnoid villi aren't draining and reabsorbing and filtering out the CSF properly, you start to get this buildup of pressure of cerebral spinal fluid in the chambers, and then the brain starts to expand outward and the skull expands, and they call that water on the brain or hydrocephalus. So we want this equal rate of production and reabsorption. Otherwise, we start to get this hydrocephalus, which is this water on the brain. The accumulation can come from either a blockage of the drainage of the CSF, maybe there's a tumor, maybe there's some developmental malformation, maybe the meninges are inflamed, or maybe there's a hemorrhage. That can create hydrocephalus. You get this increase of pressure. Common in newborn and during fetal development. The fontanelles and the sutures allow for the internal pressure to cause expansion of the skull, but it can only give so much. Then after that, and there's no more room, the brain starts to push up against the bone and it becomes life-threatening. So a neurosurgeon would have to come in and they implant this drainage shunt to drain the CSF out of the brain into the neck or down into the abdominal region. Okay, we're going to look at the brainstem, which is the medulla, the pons, and the midbrain. Okay, you can click on these links at the end. So let's start with the medulla first. It's a really important part of the brainstem, and it is protected by the top two cervical vertebrae, C1 and C2. Now, in most anatomy books, they will say that the medulla oblongata is above the magnum foramen. So they say it's in the cranial cavity, and that below the magnum foramen, where the occiput is, below that would be the spinal cord. And that's why here you'll see the spinal cord is here, and then you'll see the medulla is up here. But here's the bone, right? Here's the occiput. So if we were to draw a line here, it's debatable. Well, is this spinal cord? Well, here's where function and functional thinking and diagnostic imaging comes into play. So the reason why most anatomy books and dissection books show the spinal cord is within the spinal canal, especially C1, C2, is because when a person dies, there's dehydration and shrinkage of all of the bodily tissues. So what ends up happening is when the brain and the brain stem shrinks, it pulls up. When it pulls up, the medulla oblongata starts to ascend above the magnum foramen. But when people are living, functional MRIs clearly show the medulla oblongata protected by the top two cervical vertebrae. So yes, the spinal cord is protected by the cervical vertebrae, but at the levels of C1 and C2 specifically, that is the medulla oblongata. And the reason why this is so important is because at the level of C1 and C2, where the medulla oblongata is, there's the nuclei of the 5 cranial nerves, 12, 11, 10, 9, and 8. Okay, and you should know the cranial nerves by their names and by Roman numeral. We'll go through them. The medulla oblongata is extremely important part. It's the cardiovascular control center. It is the respiratory center. We have done several research studies, both doctors of osteopathy and doctors of chiropractic, along with cardiologists together to evaluate people with high blood pressure. And they will determine if there is any atlantoaxial instability or subluxation between C1 and C2. And if there is, and they make a correction of that distortion between the atlas and axis, and they retake the blood pressure should balance out. And this is what has been discovered for many, 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 many years. So the cardiovascular center that regulates the force of the heartbeat, your cardiovascular rate, and the diameter of your blood vessels, right? If your blood vessels open up and they dilate, your blood pressure drops. If the blood vessels constrict, your blood pressure goes up. So we want to make sure that there's no subluxation complex or neurological interference at the level of the medulla, because it will interfere with the function of those 5 cranial nerves, the cardiovascular center, and respiration. On top of that, there could be coughing, sneezing, swallowing issues. These are vomiting. All of these centers are controlled by the medulla. And all of the information that goes in and out of the cerebellum has to go through the medulla. And all of the ascending and descending tracts, sensory and motor tracts, have to go through the medulla. So this portion of the brainstem is so extremely important. There have been people who have had brain damage. They are shot. They can get a gunshot wound through the brain and they live. When I say brain, up here in the cerebrum, and they live. However, a gunshot wound through the medulla oblongata, it's instantaneous death. Why? Look what it controls: the heart, the blood vessels, and respiration. There is a fracture of C1 and C2, specifically C2, the axis. If you remember back to when you did osteology, there is a portion of the C2 vertebrae called the odontoid process, or the dens. When that fractures, it puts pressure on the medulla. That can create instant death. It just so happens that the fracture of the dens is called a hangman fracture. And that's because in the old days, if someone committed a crime and they were hung for their crime, the hope was that if they put a noose around the person's neck and they pushed the chair out of the way, that hard fall would create a snap and fracture of the dens. That's a hangman fracture. That's if they were lucky, because that's a pretty quick death. If that didn't happen, then the person sadly would suffocate from the strangulation. But the intent to that is knowing that there would be immediate neurological damage to the life center, the control center of your life, which is in the medulla oblongata. There are people who are boxers, that are martial artists, they're constantly getting their head hit back, that die. There are many that have died in the ring over the years from a hangman's fracture. They just kind of, you've seen these on YouTube videos where their whole body goes limp right there on the ring, and that's it. It's instant death. It's sad when it happens. What I want you to see here is another view of the medulla oblongata. And the reason why I want to show this view is if you look at the yellow tracks right here, you see where it says pyramids. And then if you look at the pyramids are really the corticospinal tracks. Look what happens right here. Do you see how they crisscross? How these tracks on this side of the body come over and cross over to the opposite, and then these on this side cross over, and it makes a Roman numeral X. And a Roman numeral X is called deca. So this is the decussation of the pyramid. It's these corticospinal tracts that start in the brain, where the ones on the right side cross over to the left and the ones on the left cross over to the right. It's why when there's a stroke on the left side of the brain, there's hemiparalysis or paresis on the opposite side of the body, because at the level of the C1 and C2 area where the medulla oblongata is, they crisscross. It's called the decussation. The left cortex controls the muscles on the right. In the medulla are we will talk about, I think we mentioned this last week, the cuneatus gracilis and the cuneatus, the nucleus gracilis and nucleus cuneatus. We'll talk about these. These are referred to as the posterior columns. Remember, it was the fasciculus cuneatus and fasciculus gracilis that were all part of sensory, where the fasciculus cuneatus and fasciculus gracilis dealt with proprioceptive awareness and vibration and two-point discrimination. The fasciculus gracilis dealt with the lower extremity, whereas the cuneatus dealt with the upper extremity. Let's talk about the 5 cranial nerves, 8 through 12. And you'll see them from now on. They'll be written in Roman numeral. We're going to go backwards. We'll start at 12 and then we'll go back. So the 12th cranial nerve is the hypoglossal nerve, and this moves the tongue. It controls the tongue during speech and while you're eating and trying to swallow. Pretty straightforward. If it's injured, the tongue will deviate to the injured side. So we would say to a person, stick out your tongue. The tongue should go straight out. If it deviates to the left or it deviates to the right, this is one of the things we check for to see if a person has medulla damage or if they have a stroke. We want to make sure the tongue can protrude straight out. We don't want to see any type of deviation, not just of the tongue, but even if they say, ah, we want to see the uvula in the center. We don't want to see that deviate to either side as well. Cranial nerve 11 is the spinal accessory nerve, and this cranial nerve deals with the skeletal muscles of the back of the throat the soft palate, and two very important muscles, the SCM, the sternocleidomastoid, and the trapezius. Years ago, I had a woman who, when she came in, she spoke like this. Now, I'm not teasing her, I'm not making fun of her. I'm trying to explain so you can understand how she spoke and her visual presentation to me. But when she came in, she would speak like this. She had to really control the air as it came out of her nose and mouth. Now, why was that? And she would come in like this. She would have her pocketbook on this side because this side was down low. This was the position. She was in a horrific car accident that had her helicoptered at that time on Hempstead Turnpike. It was Nassau County Medical Center. And they put her in a halo. They put her in this metal bracket completely bolted into her skull because she fractured the top 4 vertebrae in her neck in this accident. One of the cranial nerves that was damaged was the spinal accessory, which controlled the skeletal muscles on the back of the throat, which is why when she spoke like this. Eating, she had to really focus on eating and swallowing. She couldn't turn her neck, and the trapezius atrophied on her right side. So the right side was low, the left side looked high, but the left side was normal in its muscle tone. It was the right one that atrophied because the upper trapezius. So she couldn't elevate the right scapula. So the pocketbook always went on this side because if it was on the right side, it would just slip off. Okay, the vagal nerve, which is cranial nerve 10, an extremely important cranial nerve. If you think back to sympathetics and parasympathetics, we said that the sympathetics is referred to as the thoracolumbar outflow or the thoracolumbar output because it goes from T1 to L2. We said that the parasympathetics are cranial nerves 3, 7, 9, and 10, and sacral segments S2, 3, and 4. Cranial nerves 3, 7, 9, and 10, and S2, 3, 4 that keeps the feces off the floor. 90% of the parasympathetics comes from this one right here, the vagal nerve. It just doesn't control the heart, the smooth muscles, but the muscles of the viscera, everything. If you look at this picture right here, you will see that the vagal nerve goes to every single organ that you see here. You see the lungs, you see the heart, you see the liver, you see the kidneys, the spleen, the stomach, the pancreas. So by affecting the neural system at the C1 and C2 vertebral level and removing any neurological irritation that may be there, it can positively influence any type of dysfunction of these organ systems. Now, in one of the videos that we showed you in Moodle on Montel Williams, you saw the importance of an adjustment of the C1, C2 vertebrae from Montel Williams, who was suffering with multiple sclerosis. Now we have the area of C1 and C2. If we think of traumatic birth, there is a traumatic birth syndrome, right? There is birth or delivery that could be traumatic from either forceful pulling on a baby's neck. It could be a traumatic C-section delivery. It could be forceps delivery, or it could be from a vacuum extraction. And I have video content of all of these type of births because I've taken care of so many infants over the last 25 years that have had birth trauma and have had associated symptoms after birth trauma, where babies couldn't hold down breast milk. They would projectile vomit across the room, or any liquid or food they couldn't hold down. It would just projectile vomit due to severe subluxation of the atlas from traumatic birth, affecting the vagal nerve. And the vagal nerve controls the sphincters between the esophagus and the stomach. So if that valve between the esophagus and the stomach doesn't open to allow food in and it stays shut, the food just keeps on piling up, and then the baby has the gag reflex and vomits projectilely across the room. There was a Dr. Gottfried Gutmann, he was a German physician who autopsied over 1,000 babies who died of sudden infant death syndrome, called SIDS, sudden infant death syndrome. And what this physician discovered was that 100% of those babies that died after autopsy, they all had what he referred to as atlantoaxial instability. Atlanto is Atlas, axis is C2. So C1, C2 instability. If those two vertebrae are not stable and they're impeding or putting pressure on the medulla oblongata, it's very likely that now the breathing center shuts down. The cardiac center, remember the medulla controls heart and lungs. It just stops. Now you have the baby who is forcefully rotated with the head and tractioned and pulled out. Now you have neurological irritation of the upper cervical spine. And now the baby, if sleeps on the stomach with the head turned, creates more neurological irritation and the life force shuts down. That could be to the heart, they call it crib death, or sudden infant death syndrome, which is why babies who have traumatic birth syndrome, they do the APGAR scoring. What is the heart rate like? Is the baby crying? Is the baby peeing? What is the temperature like? Right? They look at the baby color, all these things for the baby's APGAR score when they're born. So whenever there's any type of visceral or organic dysfunction after birth, if there is the possibility of any type of abnormal trauma from the delivery, easiest thing to do and the most direct thing is go right to the neurology at the C1, C2 level and assess the integrity of it. So when you look at that vagal nerve and you see, could that be the cause of the person's acid reflux? Could that be the cause of the detoxification issue? Could that be the cause of their insulin dysregulation? Could that be the cause of their constipation or diarrhea? Could that be a cause of their cardiac arrhythmia? Could that be the cause of the chronic bronchitis or asthma attacks? So many different variations of diseases from neurological dysfunction. Cranial nerve 9, glossopharyngeal nerve. Now, cranial nerve 9 deals with the parotid gland, which is over here near the masseter muscle in front of the ear, and it is a type of salivary gland. Cranial nerve 9 also lifts the throat during swallowing. Cranial nerve 9 deals with the taste of bitter to the posterior 1/3 of the tongue. So if cranial nerve 9 does the taste of bitter to the posterior 1/3 of the tongue, what does sweet, sour, and salty? Sweet, sour, and salty is cranial nerve 7. Just remember 7, sweet, sour, salty 7, sweet, sour, salty 7, sweet, sour, salty 7. But cranial nerve 9, on the other hand, bitter back 9, bitter back 9. The posterior 1/3 of the tongue is bitter. When the doctor is checking your reflexes, if we think you have brain damage and we say ah, and we look at the uvula and we look at the back of the throat should elevate symmetrically. If one side elevates and there's drifting or lag on the other, then there's cranial nerve 9 issue. They should both elevate when you say ah. If the uvula deviates to one side or the other, there's cranial nerve 9 damage or medulla damage. Okay? Should be able to tap the back of the throat or touch the uvula, and then it stimulates the gag reflex. Cranial nerve 9 is the sensory part of the gag reflex, and cranial nerve 10 is the motor part. It makes the actual muscle contract. Cranial nerve 8. Look at that name of that nerve. It's got 2 words in there, vestibulo and cochlear. Vestibulocochlear nerve. Cochlear deals with the hearing. The vestibular portion deals with your sense of balance. So the cochlear is hearing. If the cochlear portion is damaged, you can have deafness. You can have ringing of the ears called tinnitus. This is why it's so very important if someone is taking a medication or a patient has tinnitus, it's important to look at the medication they're taking to see if that medication is referred to as ototoxic. Ototoxic means it could be damaging to the ear, either sense of balance or hearing. A classical medication that's known to create tinnitus is aspirin. Any type of overdose in aspirin can cause tinnitus or tinnitus, which is ringing of the ear. But there's numbers of medications that can do that. Balance is controlled by the vestibular apparatus of the ear. When someone has the feeling that they're spinning, we call that vertigo. When someone has the ability to walk, balance in a balanced manner, we say they have an ataxic gait. For example, if you've ever seen someone who's under the influence or is drunk and drank too much alcohol, they don't walk with their feet together. They walk with their feet staggered wide apart. That is an ataxic type of gait. They have more balance when their feet are wider apart than if they're walking with their feet together. The vestibular apparatus in the ear, those are called the semicircular canals. There's an anterior canal, a posterior canal, and there's a transverse or lateral canal. So when you move your head forward, you stimulate the anterior canal. When you move your head back, the posterior canal. And when you rotate your head right and left, that is the lateral canals or the transverse canals. Oftentimes, there's a little crystal that can get lodged in any of these vestibular or semicircular canals. If the person looks up and they turn their head back and to the right, and they look up this way, and all of a sudden they feel like they're going to fall, that's vertigo. That is a right posterior canal issue. If I move my head forward and to the left a little bit, that's the left anterior canal. And if I feel like I'm going to fall and my eyes go into a nystagmus and I can't maintain my balance, that's the anterior canal damage causing vertigo. If I turn my head to the right and my right canal is damaged, the right transverse canal, my eyes will start oscillating back and forth called nystagmus. Whenever positioning of the head triggers a vertigo, they call it a BP, they call it a benign paroxysmal positional vertigo. Benign paroxysmal positional vertigo. It basically interprets to anytime they change the position of the head, they get vertigo. That's benign paroxysmal positional vertigo. Most physicians give their patients motion sickness medication for this. This can be fixed in most cases in about 5 to 6 minutes. I get about maybe 12 a year, 12 cases of this that I treat a year. Fixable in about 5 or 6 minutes. They end up kicking themselves in the butt. Why didn't they come sooner? The medications weren't helping. And for the most part, if it's a BPPH, it is fixable. If it's a vertigo that's created by a chemical, let's say an ototoxic drug or blood pressure medication, those are very, very difficult to fix. But if it's mechanical, completely fixable. So here is the medulla. Here is the vestibulocochlear nerve. And you could see this is the cochlear, this is the vestibule. So it's the vestibulocochlear nerve. This is for your hearing. Here's the anterior canal, posterior canal, and the transverse canal. So how does hearing happen? Well, you should know this from lab, right? The sound waves come in, they hit the tympanic membrane, they make this membrane vibrate strong. The vibration moves into the bones, the smallest bones of the body. It moves into the malleus, the incus, and the stapes. And then you have the oval window here, and it creates this oscillation, this in and out kind of movement, back and forth, which creates the suction phenomenon. and starts to move the fluid in the cochlea in a particular vibration and converts this vibrational frequency into a nerve impulse. And that's how we hear. It goes into the temporal lobe for hearing. This vestibular apparatus in the vestibule, in these canals, you have these little hairs, and these little hairs get stimulated by a crystal. A little crystal moves from the ampulla and it starts to move through the canal, and it stimulates the hairs and it tells you what position your body is moving. And when you're done moving, that crystal should start to slide back, and it goes back into the ampulla back here in the dilated part. If it gets jammed and stuck in here, that's what gives the vertigo. And if you think of when you were little and you went to, let's say, some amusement park or some festival, sometimes they give you that cheap little maze, right? It's like a little circle and there's a little BB, like a metal ball in there, and you have to maneuver the ball to get it through the maze into the hole. That's what it's like when I'm treating someone with a crystal that's stuck in this canals. Once I diagnose what area and which canal the crystal is lodged, I have to maneuver the head very slowly and carefully to get the crystal that may be lodged in this posterior canal and get it back into the dilated part so that they don't have the dizziness anymore. Okay. All right, so that's the importance of the medulla. Hopefully you understand how critical it is. You understand those 5 cranial nerves, 8, 9, 10, 11, 12, know them by Roman numeral, both know them by their name, and I would know their primary functions. Above that is the pons, and the pons means bridge. In the bridge is 2 important areas called pneumotaxic and apnoistic. And in there you see pneumo, like pneumonia. Okay, that means breath or spirit. So the pneumotaxic and apnoistic area helps to control the pause and the rate and rhythm of the breathing. So when you breathe in and then you breathe out, there's a pause, and then your body knows when to take the next inspiration. So that's controlled by the pons. In the pons, we have cranial nerves 5 through 7. Okay, 5 is the trigeminal, 6 is the abducens, 7 is the facial. Now, there is part of the vestibulocochlear nerve, the cranial nerve 8, that originates in the pons. Part of 8 is in the medulla. That's the cochlear portion. The balance portion originates in the pons. That's the vestibular branch of the vestibulocochlear. Okay. All right, so let's look at cranial nerve 7. I touched upon 7 before. When I did cranial nerve 9, I said bitterback 9. Then I said, well, what does sweet, sour, and salty to the anterior 2/3 of the tongue? Well, that's cranial nerve 7, the facial nerve. Facial nerve does sweet, sour, and salty to the anterior 2/3 of the tongue. It also deals with the muscles of facial expression. That means smiling, frowning, raising your eyebrows, puckering up for a kiss. That is all facial nerve. When there is damage to the facial nerve, you get what's called Bell's palsy or facial nerve palsy, where half the face droops. You smile and only half the face moves. You could see cranial nerve 7 damage because when someone blinks, only one eye blinks and not the other. Cranial nerve 7 is responsible for shutting the eye and helping you blink. When we get to cranial nerve 3, you'll see cranial nerve 3 is responsible for keeping the eye open. So if the eye can't stay open and it droops, like it shuts, that's because there's cranial nerve 3 damage. The eye can't stay open. But when you blink and you can't close it during a blink, that's cranial nerve 7 damage. Cranial nerve 7 is sweet, sour, salty, and salivary. It controls the salivary glands, right? The sublingual, the submandibular, but not the parotid gland. The parotid gland is cranial nerve 9. Abducens. If you look at the word abducens, the first three letters, you should see the word abduct, abduction. So cranial nerve 6, the abducens nerve, is responsible for abducting the eye. So if I were to cover my eye like this, and I put a pen in front of my eye, and I say, okay, I'm going to follow it to my right, now the lateral rectus on my right side is deviating my eye laterally. So what cranial nerve is responsible for abduction of the eye? Cranial nerve 6. What nerve goes to the lateral rectus? Cranial nerve 6, abducens. Trigeminal. If you've watched my lecture on this before, you've heard of my painful story regarding the trigeminal nerve. Trigeminal nerve controls the muscles of mastication of the face. What are the muscles of mastication? Mastication means chewing. The muscles of mastication are the 4 chewing muscles: time, T-I-M-E. Temporalis is the T. The M is for masseter. What's the I and the E in the word time? The I is for internal. The E is for external. Internal and external what? Internal and external pterygoid muscles. Pterygoid is spelled with a silent P, P-T-E-R-Y-G-O-I-D. So temporalis, internal pterygoid, masseter, and external pterygoid. Those are the muscles that help you chew. Those are controlled by the trigeminal nerve. That's the motor portion. The sensory part is that cranial nerve 5, the trigeminal nerve, has 3 branches. They call it VI, VII, and VIII. V because of Roman numeral 5. V1 is the ophthalmic branch. It goes to the lateral part of the eye. V2 is the maxillary branch going to the maxilla, top jaw. V3 is the mandibular portion that goes to the mandibular section, the bottom jaw. V1, V2, V3. That's the sensory part. So you can feel, if you touch your face and you feel it, your trigeminal nerve is working fine. It's the only cranial nerve that actually has a dermatome. No other cranial nerve deals with the touch like that, sensation. When the trigeminal nerve gets irritated, you get what's called trigeminal neuralgia. Anything that ends in algia means pain. Neuralgia is nerve pain. So trigeminal neuralgia is lightning, lancinating, shooting, suicidal pain. That's how bad it is. And I experienced it once in my life. On one day, twice, because of a dentist. And it was a new dentist in my area, and I wanted to introduce myself, and she said, oh, let me do a complimentary exam on you, and it would be great if you could tell your patients about me. So I had her do an exam, and she said she had found a cavity, so she wanted to fill it. She injected me with Novocaine, and when the needle went in, she actually hit the trigeminal nerve. And when she hit it, I got the trigeminal neuralgia, just lightning pain to the entire side of the face. It was the most pain I have ever experienced, secondary to a major surgery. She then went a second time. Oh, I'm so sorry, please, let me try it again. She did a second time, she hit the nerve a second time, and I just ran for the doors. I escaped. Trigeminal neuralgia is very painful. It's knife-like, lancinating, shooting pain to the face. I wouldn't wish it upon anyone. You can see here the 3 branches, V1, V2, V3. So when they hit this trigeminal nerve, when they hit that ganglion, boom, you get lightning to half of your face. All right, let's look at the midbrain now. Okay, so the midbrain, right, here's the medulla, we did that. Here's the pons, we did that. Now we're gonna look at this section right here called the midbrain. There are a few important areas in the midbrain that we'll talk about. I will mention the corpora quadrigemina. I will mention the substantia nigra, and I'll show you the red nucleus. So a little silly saying for the midbrain, for the 3 main parts. It's red, black, the twins in the back. Red, black, twins in the back. That's for the midbrain. Let me show you what that is. Here is the red for the red nucleus. Here is the black, substantia nigra. It means black substance. And the twins in the back, I will show you a back here, these two bumps. But there's actually 4 of them. So we call them the twins in the back. The substantia nigra, the black, is very, very important. The substantia nigra is involved in producing dopamine. It's this neurotransmitter that's involved in controlling muscle activity. It is the issue with dopamine, or the issue is when the midbrain or the substantia nigra is involved and you can't produce dopamine, you get a disease that's known as Parkinson's disease, where you start to see as people move, they get these rolling tremors. As they start to move, they get these shakes, or you see the head starts to bounce and move around. You see the face expressionless. They call it a mask-like look of expression. When they go to walk, they have what's called a festinating gait, which is where they are shuffling their steps, very, very small, rapid steps. But in order to take the first step, they have to lean their body forward. They have to bend forward a little bit to lose their balance. And as they bend forward to lose their balance, it allows them to take these fast, rapid steps. That's Parkinson's disease. Okay, so where's the twins in the back? The red was the red nucleus, the black was the substantia nigra. Now, right here are the twins in the back. It's called corpora quadrigemina. It's the 2 superior colliculi and the 2 inferior colliculi. 2 superior and 2 inferior colliculi. These 4 structures, the body of 4, or the corpora quadrigemina. Corpora, from corp or corpus, it means body, and then quadrigemina, quad is 4. The superior colliculi is involved in eye movement with visual stimulus. So if I were to say, follow my thumb and I'm moving it side, or read something and your eyes contract properly, that involves the superior colliculus. If there's this loud bang, if you hear a loud sound, then your head turns in conjunction to seeing and hearing that sound. That's the role of the inferior colliculus. That coordinates head movements when there's a loud auditory stimulus. So when you hear superior and inferior colliculi, or corpora quadrigemina, or substantia nigra, you're thinking midbrain. And in the midbrain, we have cranial nerves 3 and 4. Cranial nerve 4 is the trochlear nerve, controls the superior oblique. That's all it does, superior oblique. The oculomotor, the 3rd cranial nerve, is responsible for, as I said earlier, keeping the eyelid open. Think of 3 columns keeping the eye open. If there's cranial nerve 3 damage, you get what's referred to as ptosis, P-T-O-S-I-S. Ptosis is when the eyelid closes. That's ptosis. Cranial nerve 3 goes to all of the other eye muscles, the other 4 eye muscles, right? We said that the abducens nerve goes to the lateral rectus. We said the trochlear goes to the superior oblique. So there's 4 other eye muscles that we didn't mention. That's controlled by the oculomotor nerve. The 2 intrinsic eye muscles. These are going to constrict the eye and the lens and the pupil to help you accommodate to read or for vision, right? Those 2 intrinsic eye muscles are going to change the shape of the lens to help you read. And then it may alter the shape of the lens to see something far distance. Cranial nerve 3 is also involved in constriction of the pupil. So if I were to take my pen and I were to shine this light into the pen or shine it into my eye, the pupil will constrict. When I move it away from my eye, the pupil will dilate. So that's called the direct light reflex. If I go like this, and I put this light and I shine it in my right eye, the right eye should constrict. That's called the direct light reflex. But at the exact same time that I shine it into my right eye, you, the observer, could analyze my other eye and you'll also see it constrict. That's called the indirect light reflex. In order for this to happen, the first thing that has to happen is my eye has to actually see the light. In order to see the light, what cranial nerve has to work? Cranial nerve 2. That's the optic nerve. So the optic nerve sees the light, relays the information to the oculomotor, and it makes the pupil constrict. That's called the light reflex. It involves cranial nerve 2 and cranial nerve 3. Cranial nerve 2 is sensory because I sense the light. Cranial nerve 3 was motor, oculomotor, that made my pupil constrict. The reticular formation is a combination of so many different parts of the brain that helps to regulate muscle tone. It alerts the cortex to all of these incoming signals, and it's responsible for helping keeping me awake. It keeps me up. So there were times that I can recall observing in class, traditional classroom setting, on campus, where sometimes I'd be lecturing, and if a student was up pretty late, I would see them start to do this. Reticular formation not working too well. I'd see them doze off. And then I'd say, okay, class, I'd say something loud, and they do this, right? It was that incoming signal that alerted them. It's the same thing where, do you sleep through your alarm clock when it goes off? Or can you wake up? If you're sleeping and you smell smoke, do you wake up or sleep through the fire? So you need to have a healthy reticular formation for that. Okay, so these are, the reticular formation is nothing other than a bunch of scattered nuclei throughout the medulla, through the pons, through the midbrain, right? Through all of those three parts that we've just covered. That's called the RAS, the reticular activating system. And it helps to maintain your consciousness. It helps to maintain posture, right? Like when that person woke up, what happened? They were like this. And as soon as they heard something, the muscles kicked in and it pulled them up and to maintain their posture and their muscle tone. Okay. All right, let's move through. Again, you can review those on your own, but we've covered them in pretty good detail. Let's look at the cerebellum now. And the cerebellum, we call it the little brain. It occupies the posterior and the inferior part of the cranial cavity. And it too, like the cerebrum, has two hemispheres, a left and right cerebral hemisphere that is separated by the vermis right in the center, the central vermis. The primary function is to correct any voluntary or postural imbalance, right? It's designed to coordinate your muscle contraction and your posture. So again, if I said, okay, here's my finger and here's yours, touch my finger, it's nice and smooth. Sometimes I'll test my patients and say, here's my finger. I don't want you to touch my finger. I want you to stop about half an inch before you touch my finger. And what I look for is a slight tremor at the very end. You have to have a good eye to catch it. So if you can go from here to here and it touches, no problem, and that's smooth. But what if we say stop and you start to see that? They go and they touch, it looks smooth, and they stop and you see a tremor. Cerebellum. It deals with equilibrium. It deals with coordinating skeletal muscle contractions, maintaining normal posture, normal tone, and your balance. If you're walking straight and you start to deviate to the right, there's a problem. If you stand still and you deviate to the left, there is a problem. So here is the cross section of the cerebellum from the lateral perspective, or sagittal view. And there's white matter and gray matter. The white matter is the arbor vitae. It's the veins of the leaf. And then we have folia, which sounds like foliage, leaves. That's the gray matter. So the cerebellar cortex is gray matter, and then the inner part, the veins of the leaf, is white matter. So you got arbor vitae and folia on the outside. Let's talk a little bit about the diencephalon. Remember, anything with the word thalamus in it, you have to think diencephalon. Thalamus, hypothalamus, epithalamus. So the thalamus, now you do not have to memorize all of these nuclei, but I want to show you how complex the thalamus is, because the thalamus is the relay station for all of the sensory input that comes into your body, except the sense of smell, right? The thalamus don't stink. All of these different nuclei that we see here are relay stations for input coming in. And then the thalamus says, okay, I'm going to send you up to the postcentral gyrus. And since this information is coming from the right foot, I'm going to send this information to the left cerebral hemisphere, to the postcentral gyrus, to this very specific region, so this individual can identify that they have left heel pain compared to the left great toe pain or something like that. Okay? So the thalamus is the relay station for all sensory input, whether it's seeing, whether it's hearing, whether it's certain discomfort from different body parts, all of the sensory input except for the sense of smell. So there's the thalamus, right? It's that kidney bean-like structure right there. Again, it's the relay for all the sensory input, ascending up. Now, don't confuse thalamus with the hypothalamus. Hypo means under. So under the thalamus is the hypothalamus, and this is such an important major area for regulating homeostasis within the body. The hypothalamus regulates homeostasis by a variety of ways. It is involved in integrating and controlling the ANS. Well, what is the ANS? The ANS is the autonomic neural system. What is the autonomic neural system? Sympathetics, parasympathetics. Sympathetics, fight or flight response, thoracolumbar outflow or output. Parasympathetic, feed or breed, rest and digest. Craniosacral outflow, because it's cranial nerves 3, 7, 9, 10, and sacral segments S2, 3, 4. So that alone should be like, wow, now there's this amazing connection between the hypothalamus and the brake and the accelerator, right? Sympathetic and parasympathetic. The hypothalamus works closely with the pituitary, both the anterior pituitary and the posterior pituitary. When we get into endocrinology in Bio 204 or Anatomy 2, you will understand that the anterior pituitary is involved in producing about 5 to 6 different hormones: thyroid stimulating hormone, growth hormone, luteinizing hormone, melanocyte stimulating hormone. There's so many. And then the posterior just deals with oxytocin and antidiuretic hormone. When we cover endocrinology in the next upcoming class in AMP2, we'll talk about these hormones and what they control and coordinate. But here, the hypothalamus works in very close correlation with the adenohypophysis, which is the anterior pituitary, and the neurohypophysis, which is the posterior pituitary. It's involved in regulating rage, aggression, pain, pleasure, arousal. It tells you when you're thirsty. It tells you when you're hungry. It tells you when you're full. Most eating disorders take place in the hypothalamus. It's not that, when you watch the documentary on the Discovery Channel of the 1-ton man or 1,000-pound woman, it's not that the person loves eating Twinkies and Oreo cookies. It's not the case there. We're talking about neurological damage where the hypothalamus is never getting the message that they're full. We all know what it feels like to be hungry. And when you're really hungry, you're like, oh my God, you just want to eat really quick to make yourself feel full. But imagine eating and never feeling full. That's the problem when you have the person that's 1,000 pounds. It's a neurological lesion where they're never getting that feeling of feeling that they've eaten enough. So they keep eating and eating and eating. Okay, the epithalamus is important because this is where the pineal gland lies. The pineal gland is this small pea-sized gland that secretes melatonin, not melanin, right? Melanin was involved with skin pigmentation. Melatonin is a hormone that the body creates and secretes at nighttime. I have a very good friend that I went to high school with, and he and I both took the New York City police test back in the 1990s, and he moved forward and became a police officer who just recently retired. And I was in an automobile accident that brought me into a doctor of chiropractic, which changed my life. So we went separate ways. We remained friends all of these years. All of these years, we speak about at least twice or 3 times a week. Anyway, the reason why I bring him up is he worked the night shift. So he'd work midnights. He wouldn't get home till 7, 8 in the morning when the sun was coming up. So he would go home and he bought a condo when he was living in New York on Rockaway Beach. He bought a beautiful condo before the bad storms that came. And he bought a massive condo that had this great master bedroom with a huge walk-in closet. And I remember when I saw his place, I said, "Where's your bed, buddy?" Didn't see his bed anywhere. He opened up the walk-in closet, and that's where he put his bed. Why? So that it was no windows, completely dark, and he could sleep in the daytime. Okay, there's so many complications that take place without sleep. So he tried, this melatonin only secretes during complete darkness. So how is it going to work when you get home and it's daytime and you're trying to sleep at 9 o'clock in the morning? Difficult to happen. So it promotes sleepiness. There's another nuclei, that's the habenular nuclei, that deals with the emotional response to odors. So if someone's wearing a cologne or perfume, you can go, that smells delicious, or wow, that smells great, or grandma's pie, oh, yummy, right? An emotional response to certain scents. All right, let's talk now about the cerebrum. And the cerebrum, what separates the left from the right hemisphere is a longitudinal fissure. So when I say separates, you can probably, when I remember dissecting the human brain, we've also done it in labs as well at the university. You can't really pull it apart. You can put your fingers in and separate, and you can feel the separation between the right and left cerebral hemispheres. You can't really separate them into two halves without using a scalpel and cutting it with a knife. So the longitudinal fissure creates this delineation between the left and the right cerebral hemispheres. But they are connected by the corpus callosum, which is a band of white matter connecting the left and right hemispheres. The corpus callosum is this band of white matter that's thicker and stronger in women than it is in men. So women have a much better communication system between both sides of the brain, talking back and forth. The cerebral hemispheres are divided into 4 lobes. Those four lobes are the frontal lobe, parietal lobe, occipital lobe, and the temporal lobe. So let's see if I can show you some of those lobes and the fissures. So let's look at the longitudinal fissure. So you see the green right there? That's the longitudinal fissure separating into a left and right cerebral hemisphere. What's the other one I want you to know? This yellow one right here. The yellow one is called the central sulcus. The central sulcus is important because from this view, we can see the precentral gyrus and the postcentral gyrus. And from the lateral view, if we look at the bottom picture, there's the central sulcus there. And again, the yellow line delineates and separates the precentral gyrus from the postcentral gyrus. Motor strip, sensory strip. If we look at the different colors, I like this. So this like pink area, the light pink is the frontal lobe, the dark pink is the precentral gyrus, the lavender is the parietal lobe, the dark purple, postcentral gyrus. The groove between the pre and postcentral gyrus we went over earlier, central sulcus. Occipital lobe is the visual center, temporal lobe is for the hearing, parietal lobe is for your proprioceptive awareness, perception of your body parts. Frontal lobe, we said it's your personality, it's your ambition, it's your drive, it's the inhibitory center, right? Like people who do road rage, right? Someone accidentally cut someone off. Accidentally, they didn't see them in maybe the side mirror, and then that person, races up. They look at them with a baseball bat or something, pull over, and they, that's road rage. That's a frontal lobe that's majorly disturbed. Why? Because they have the inability to simply say, maybe they didn't see me. Maybe, just maybe, right? Maybe it wasn't done on purpose. Okay. All right, let's see what else we have. So here is a nice view of both hemispheres, but you can see the corpus callosum, right? It's this band that goes back and forth, connecting the left and right side of the brain. There are projection fibers that connect on the same hemisphere of the brain, but the corpus callosum, left and right. The longitudinal fissure separates the right from the left cerebral hemispheres. Okay, you didn't hear me mention the basal ganglia very much. The basal ganglia is a very, very complex area, deep near the diencephalon of the brain. And all you really need to know about the basal ganglia is that it's really involved in controlling large automatic movements of skeletal muscle. Let me give you an example. You are rollerblading, you are ice skating, and you accidentally lose your balance and you're about to fall, but your right arm flings out this way, your head moves left, your left arm moves out, and you move your body in this kind of uncoordinated way, but yet it's done in the right order sequence without any conscious thought, and you're able to restore balance. That's the basal ganglia. The basal ganglia works when you walk and your arms have this natural swing. It's very predictable when you see someone walking that doesn't have arm swing, there is brain deterioration. When you see someone walking and one arm swings but the other one doesn't, and it is not swinging properly, not because maybe they are in shoulder pain or they had some major surgery, right? I'm not talking about the obvious here. This is usually an early indicator of Parkinson's disease and Alzheimer's disease. When you don't see healthy arm swing, there's major neurological decline, typically Parkinson's or dementia. With Parkinson's and dementia, we always like to test cranial nerve 1 for sense of smell, because it's one of the first things that's lost when there's neurological decline is the sense of smell. and we use a scent that everyone recognizes. I'll give you an example. Everyone knows what coffee smells like. Everyone knows what cinnamon smells like. Everyone knows what peanut butter smells like. So you can take peanut butter, hold it about 10 inches from the nose, ask the person to keep their mouth closed, not open, closed, and have them inhale and ask if they can identify the scent. If they can't, and there's lack of arm swing, it's pretty predictive. I would get them to a neurologist and have them assessed for dementia, Alzheimer's, or Parkinson's disease. So the limbic system, you see there's a lot of moving parts here. The biggest and probably most important ones are like the hippocampus is a big area. The fornix you probably learned in the lab section. All of these terms, whether it be amygdala, cingulate gyrus, fornix, hippocampus, they're part of the emotional brain. The limbic system is part of the emotional brain. You can see the olfactory nerve, the olfactory bulb, cranial nerve 1, has connections not to the thalamus, but to the limbic system, so that you can go, that smells delicious. Or, I smelled that before. Last time I ate that, it made me vomit, right? So it's part of the emotional brain. The more intense the pleasure or the more intense the pain, then the stronger the memory. The stronger the emotion, the stronger the memory. You will always remember the teacher that made you laugh, the teacher that challenged you the most. You'll always remember those because there was an emotional response associated with it. You'll remember when I was a kid, I went to see a movie called E.T. Everyone cried when they saw E.T. We were like, oh, we never cried at a movie theater. You got 7-year-old kid, 8-year-old kid crying, and I'll never forget the movie. It was a strong emotional response. Comedies. People remember the next line to a comedy because it made them crack up. They nearly peed on themselves. That's how funny it was. It's the limbic system and the emotional brain. Okay, now we're looking at these numbered areas. You know, when they say you only use 20% of the brain, thanks for playing. It's nonsense. We use 100% of the brain. Every part is localized. Every part is numbered. They know what each part does. I think at the time that saying came out that we only use 20% of the brain, at that time, I think they only knew what 20% of the brain did. But there's no waste. There's no dead tissue there. Everything has function. So the primary somatosensory area, aka postcentral gyrus, that's here. That's 1, 2, 3. Remember, here's the central sulcus. The primary visual area is back here on the occipital lobe, number 17. Now, I'm not going to ask you the numbers. You don't have to know that the primary visual area is number 17, but hey, the occipital lobe is your visual center. Your parietal lobe is the primary sensory area. Okay. Let me just move this because I can't see what the next one is. The primary the primary auditory area, as we said earlier, for hearing, this is the temporal lobe. So you can hear my voice and you go, okay, I know your cranial nerve 8 works. You can hear me. But now if we say, can you identify this person's voice, right? You know, when you watch an animated movie, you can hear the voice. We know that your 8th cranial nerve is working and your temporal lobe, but then you're trying to figure out, where do I know that voice from? That's because it's sent to a association area that's trying to interpret it. No different than number 17 sending it to number 18, which is an association visual area. If you see me, you know I see a person. I know my eyes work. But can you identify who that person is? That's the visual association area. Okay. The gustatory area for taste, that's up here. That's in area 43, which is near the post-central gyrus. Again, this is sensory, all sensory information. Okay, now let's look at the motor side. So here's the central sulcus. Number 4 is the pre-central gyrus. That's your primary motor area. That's where all of your initial voluntary muscle contraction starts. Number 44, predominantly on the left side of the brain, is called Broca's area. That is your motor speech area. When there is lack of blood supply to the left side of the brain in number 44, this is when you have seen people on the news, the Home Shopping Network. Through the years, we have seen so many have these mini strokes on the air, on TV, and they just start babbling, and there's no sequence or order to what they're saying. They think they're communicating something, but they're not. That's because they're having a stroke or there's decreased glucose in blood and oxygen to the motor area that controls speech, which is Broca's area number 44. If there's damage to the left side of the brain, there'll be speech that's impaired with hemiparesis to the right side of the body. Some of the association areas. Okay, so number 4 was the primary motor area. Then we have, I'm sorry, 4 is the primary motor, 1, 2, and 3 is the primary sensory. Well, what connects to the primary sensory area are these secondary areas that are going to try and interpret and integrate that. So it's associating with other parts of the brain. Again, number 17 is the primary visual area, but it's going to connect to 18 and 19 to allow you to interpret, recognize, and evaluate what it is you see. The auditory association area, Wernicke's area, which is number 22, right here near that temporal lobe. This area allows you to hear words and to understand what they mean in terms of speech. Do you understand what someone is saying? That is the Wernicke's area. It gives words their meaning. Number 8 in here in the frontal lobe, it's the frontal eye field. So if I say to you, look at my thumb, and I want you to follow and follow this, these are called pursuits, right? If you can pursue and follow my thumb as I go left to right, I know the frontal lobe is working pretty good. But the parietal lobe does this. If I say, look at my nose, and then I wiggle this thumb and your eye moves to the moving thumb, and then I wiggle this one and your eye quickly moves there, and then back and forth, that's called a saccade. A saccade is the parietal lobe. It's a quick eye movement. It's not pursuing from one location smoothly to the other. Okay. The term aphasia, that's an interesting term here. The word aphasia is the inability to use or to comprehend words. That's aphasia. This is when you know what you want to say, but it's just not coming out, right? That's aphasia. Like, oh my God, I know what it is, like this. That's aphasia. Inability to use the word. And sometimes it's to understand the word. So non-fluent aphasia is different than fluent aphasia. So non-fluent aphasia is the inability to properly form the word, whereas fluent aphasia is the faulty understanding of what was said to you or what was written and what you're reading. Okay. Sometimes you can misunderstand things through word deafness, which is the inability to understand what people said, or there's word blindness, which is the inability to understand what you just read. In terms of left and right hemispheres of the brain, The left hemisphere controls the spoken and written language, numbers like math, the ability to understand sign language, reasoning, logic, science, math, that's all left. Your right side is more artsy and music. It's more, should I put this picture frame on this wall? Does the couch look better over there? Does this tie match with this shirt? Do these two things go together? So, in terms of pattern perception and space perception, that's right side. Recognition of faces. Babies are born with really strong, powerful right side of the brains because they can identify their mommy, their daddy, their parents, their grandparents, facial recognition. Babies are really strong at understanding, is the parent happy with them or angry? They can cry because they look at someone and they see teeth and they think they're angry. They look at the eyes and they may see them big and they get frightened, so they cry. Right side of the brain, if my right side of the brain was damaged, I would be talking like this to you and communicating every single thing that I taught. This term would come out like this. There is no ability to generate any emotion to the language, right? But when you have a healthy right side of the brain, you can use different tones to try and get a message across. Okay, so hemisphericity is understanding that right and left hemispheres have different functions. Females, we said, have a larger corpus callosum connecting the two sides. We also said when there's a stroke or damage to the left side of the brain, then most likely there will be aphasia due to damage to Broca's area. Okay, what I really like about this picture, there's a few things. What I like about it is that it shows how the right hemisphere here is controlling the left hand and how the left hemisphere is controlling the right hand, right? We know because in the very beginning, I showed you the decussation of the pyramids, the corticospinal tracts decussated at the medulla oblongata. The other thing I like about it is notice the corpus callosum connecting the two sides, allowing them to communicate. But the reason why I'm showing this is I also want you to look at the eyes. And I want you to see that if we look at the right eye has receptors in the back, in the retina. There are receptors on the lateral part of the right eye and the medial part. If the person is looking at something that's in their nasal, this is the nose, and the nasal field of view, that information crosses from the midline to the outer part of the eye. Okay? And that information stays, if we look at it, it stays on the same side of the brain. Notice the color is like reddish orange. Look at this area, it's reddish orange to the occipital lobe. If I'm looking at something with my right eye on the temporal side, on the temporal field of my right eye, that information crosses over to the inner receptors of my right eye. And then if we follow that, it crosses over to the opposite side of the brain. So both sides of the brain are working on both eyes for vision. Notice where they crisscross is right here, called the optic chiasm. And that's where the pituitary gland is. So if there's a pituitary gland tumor or enlargement, and it's putting pressure on part of these optic nerves, you can go blind, maybe on the right side of one eye, maybe the right side of both eyes, maybe the blindness in the entire eye, maybe the left side of both eyes, maybe the outside of both eyes, or maybe the inside of both eyes. It really depends on what part of that optic nerve is being blocked. Okay. You can also see the auditory cortex on the temporal lobe. You can see spatial awareness and visualization on the right-hand side. We can see, whoops, just get out of that for a second. Good. You can see calculations on the left side. We can see speech on the left side. So left remembers more linear, logic, math, science. The right side, more music, spatial awareness, songs, art, facial recognition. This is EEG. EEG, if you look at it, it stands for electroencephalogram. And when you're measuring muscle waves, they call it EMG, electromyography. When we're measuring cardiac waves, we call it electrocardiograph, an ECG or an EKG. So an electroencephalogram, you look in the middle of the word, you see like encephalitis, encephalo, that means through the brain. There are alpha waves, beta waves, theta waves. The alpha waves are typically your normal resting adult wave. They'll put all these electrodes on the brain and they'll give different types of stimulus and see what type of waves you normally have, or they'll try and create waves. The beta waves, if you're concentrated on something, you should see waves that look like this. Right now, as many children are at home doing homework or they're online and they're feeling frustrated, if their school closes down, then they have more theta waves. And delta waves occur in deep sleep and in certain pathological states. So this is EEG. I'm not going to ask you to identify the waves by the intensity of them, but you should know what an alpha, beta, theta, and delta waves, what they represent. Okay, cranial nerves. Again, we'll just do a quick review on them. Olfactory nerve is cranial nerve 1. It deals with the sense of smell. You'll see that the olfactory bulb has extensions that comes down. Here's the nose. Here's the nasal cavity. Here's the inferior, middle, and superior nasal concha or turbinates that swell up due to histamine. There's this all mucous membrane. So you breathe in and the odorant sticks to the mucosal membrane, rides up into the olfactory nerve, cranial nerve 1. Cranial nerves are numbered in the order that they develop neurologically. So cranial nerve 1 is the first one that develops, and for good reason. You have to smell danger, you have to smell fire and smoke. So also pay attention as to why the nasal cavity is so very dangerous in terms of spreading bacteria and viruses. If the hands have a bacteria or virus on it and you rub your nose, this is epithelium, this is mucous membrane, things can live on this, then it drives into a nerve, and look how close. There's only about 1.5 millimeters, 2 at best, of bone, and then you have all these holes. The cribiform plate within that sella turcica, that's where the olfactory bulbs extend down. So there's entrance into the nervous system right through the nasal cavity. Always make sure your hands are clean. Optic nerve, cranial nerve 2, vision. What I want you to see is how all of these receptors that the rods and the cones, right? Rods are for black and white, cones are for color vision. They sit in the eye in epithelium. So if there's any type of epithelial damage, and what they're noticing is when there's damage in the intestines to the intestinal epithelium, there's secondary damage to the epithelium in the eyes. You can get a lot of visual problems when the gut is inflamed or the intestines are inflamed. There's like a matrix of communication between the epithelium of the gut and the epithelium of the eyes. Again, this is a great picture showing how, if I'm looking at something here in the nasal view, that information is going to hit this. Now let's follow this nerve tissue. Let's follow it. This is going to stay on the same side of the brain to the occipital lobe. And look, There's the thalamus. All the sensory input goes to the thalamus. Now I'm looking at something in the temporal field over here. That hits this, right? The information moves diagonal to the inner part of the eye. Let's follow that neuron. That one crosses over to the thalamus to the opposite side of the brain. And look at the pituitary gland. Can you understand why, if this becomes enlarged, if it pushes this way, it's going to hit this red neuron, which means there's going to be blindness to the temporal field of this eye. If it pushes out this way and hits the green here, then there's going to be blindness to the temporal part of this eye. Okay. In terms of reflexes, the corneal reflex, this is what happens when something touches your eye and your eye blinks, right? If a bug goes in your eye or an eyelash and your eye closes, that's the corneal reflex. The fifth cranial nerve, which is the trigeminal nerve, remember that is sensory. There's the ophthalmic, maxillary, and mandibular branch. So the corneal reflex picks up sensation to the eye. Once something touches the eye, then we said cranial nerve 7, which is efferent, which is motor, shuts the eye. We said when 7 is damaged and the person blinks, the eye is not going to close, only the other one closes. So the corneal reflex has a sensory and a motor part, or an afferent and efferent part. The trigeminal nerve, cranial nerve 5, is the sensory, cranial nerve 7 shuts the eye. The direct and indirect light reflex I mentioned earlier, shining light into the eye. Cranial nerve 2 is the sensory part. Oculomotor, or cranial nerve 3, is the motor part that makes the pupil constrict. The direct light reflex is if I shine light in my right eye and the ipsilateral pupil, which means the same pupil, constricts, it's good. The indirect, or the consensual light reflex, is when I shine light in my right eye and the left pupil constricts. That's what's supposed to happen. They communicate, both of them. This is nice because it shows cranial nerve 3, cranial nerve 4, cranial nerve 6, 3, 4, and 6, and then it also shows the muscles that they go to. So cranial nerve 4 goes to the superior oblique. Cranial nerve 6 goes to the lateral rectus. The other 4 eye muscles are controlled by cranial nerve 3, the oculomotor. Trigeminal nerve, that's cranial nerve 5. This is the one that has sensory to the ophthalmic division, maxillary division, mandibular division. V1, V2, V3. Cranial nerve 5 just doesn't do sensation to the face, it controls the muscles of mastication, the temporalis, the masseter, the internal and external pterygoids, muscles of mastication. Cranial nerve 6, we said, is the abducens, lateral rectus. It abducts the eye, moves the eye away. Facial nerve, cranial nerve 7, facial expression, all of the muscles of facial expression. But it also deals with the salivary glands, the submandibular and sublingual, and it does sweet, sour, and salty to the anterior 2/3 of the tongue. Cranial nerve 8, the vestibulocochlear. You can see it splits. This picture shows the cochlear branch, and it also shows the vestibular branch. Here's the cochlea for hearing, and here's the vestibular branch with the semicircular canals. Glossopharyngeal, cranial nerve 9. We said it deals with the gag reflex and the muscles in the back of the throat. We also said that it deals with the sense of bitter to the posterior 1/3 of the tongue. Bitter back 9. Again, I'm passing through these, but you can click on these in the PowerPoint if you'd like. Cranial nerve 10, my favorite, vagus. You could see it controls all the viscera, all of the organs. We could see that it arises in the medulla oblongata, protected by C1 and C2. See, it goes to the heart, the lungs, the liver, all of the internal organs controlled by the vagal nerve. Spinal accessory, cranial nerve 11, sternocleidomastoid. trapezius. We said it also controls the muscles in the back of the throat. When my patient had the accident, she was speaking like this because she had damage to cranial nerve 9, glossopharyngeal, back of the throat. She couldn't elevate her trapezius or turn her head because of the sternocleidomastoid and trapezius muscle damage due to the spinal accessory nerve. Last nerve is the hypoglossal, controls the muscles of the tongue to stick out the tongue, elevate the tongue, depress, and retract the tongue. Okay, what we said earlier when I opened up today's lecture was that the neural system begins at around the 18th day. It comes from ectoderm, right? Endoderm and mesoderm, which is the same type of tissue that the digestive tract comes from. And that's why when you're anxious, you have diarrhea. When you're depressed, you have constipation, right? They go together. This is a nice review again of all of your cranial nerves and what their primary functions are. I'm not going to ask you directly, is it a sensory? Is it mixed? Is it motor? I'm more interested in whether or not you know their functions. I mentioned stroke earlier, which is a cerebral vascular attack, a CVA. And I said that there were two types. There was clotting, like an ischemic type, when you have coagulation or a blood clot. Could be from a thrombosis, decreased blood flow, and a blood vessel can rupture, hemorrhage. And it's important to know what type of stroke the person is happening. Some of the risk factors of stroke is high blood pressure, high cholesterol, heart disease, diabetes, smoking, obesity. Now we're seeing with COVID in the younger populations, one of the biggest complications happens to be stroke. There's clotting that seems to happen. So one of the adverse reactions to COVID in the younger population happens to be stroke-like symptoms due to this. So we can add COVID as another risk factor, not due to hemorrhagic, but causing ischemia due to decreased blood flow from coagulation. It's important to differentiate what type of stroke a person is happening because most people think, well, if they're having numbness to their lips and they're slurring their words and they have nystagmus and vertigo, that they're having a stroke, they're going to take aspirin, which is a blood thinner. It's an anticoagulant. We know that because when people take aspirin, which is a blood thinner, and they take too much of it, we start to see these little bruise marks on the back of their hand and forearm. Not that good. If they take aspirin and they have a blood clot, it's great. You save their life. But if they have a hemorrhage and they have internal bleeding due to a ruptured blood vessel, and that person takes a blood thinner, it kills them. Okay, so calling 911, calling an ambulance is the best thing. And you've heard me say this many times. Make sure within your phone you have your local fire department phone number. Most of our local areas around here, thank goodness, due to our high taxes that we pay, we do have volunteer fire departments and they have an ambulance. And if, God forbid, there happens to be an issue where someone is having a stroke and you don't know whether they have health insurance or not, call the volunteer fire department. It is a free limo ride to the closest hospital, and they do an amazing job. Thank goodness for them. So a TIA is not a stroke, it's a mini stroke. It's when there is impaired blood flow to the brain for a very short period of time. They may have dizziness, slurring of the speech. They can get temporary paralysis on one side of the body, visual issues, but it doesn't last long and there is no residual deficits. Okay, usually for that, the treatment is aspirin or an anticoagulant. There's lots of things that can thin the blood. Red wine thins the blood. resveratrol, ginkgo biloba, garlic, niacin, fish oils, garlic. These are all things that thin the blood. Now, I'm not telling you to do all those things because it can become too thin. Okay, but all of these have anticoagulation effects. AD or Alzheimer's disease, this is known as a mitochondrial dysfunction where the mitochondria aren't being fueled properly. So the brain starts to go through these phases of not being able to reason properly, not being able to read, write, talk, or eat. It tends to affect about 11% of the population over the age of 65. And it's the loss of the neurons that release the acetylcholine, this excitatory neurotransmitter. It's a major issue. And also remember I said with Alzheimer's, sense of smell is diminished and lack of swinging arms during the gait cycle. As the person ages, there is a natural decline in the loss of neurons. There is diminished capacity for sending nerve impulses to and from the brain, the diminished ability to process information. I often see when people are driving and sometimes you can't see the head of the person in front of you, and it could be this cute little old man or a cute little old woman, and the person is honking the horn. Sometimes, just pretend maybe it's your grandma or grandpa that's driving. And that maybe they need more time for processing. Yes, I do agree that at a certain age, people need to be retested. They haven't done that yet, but I think it's for the best interest of the public and safety, right? It would be horrible if a family of 5 and a baby is in a car driving with their family and someone who's older, their reflexes are diminished, they have Alzheimer's or dementia, they forget that the red light means stop and they think it's go, right? There's so many, the domino effect of something like that is horrific. And that's why, I'm for retesting. And I think everyone should be retested, I guess, maybe after the age of 60 or 70, every few years to renew the license. Make sure your eyes are good, your reflexes are good. Your brain can process information because at 50, 60 miles an hour, sometimes you don't have time to respond quickly, right? Okay, so the decreased conduction of velocity, we know that myelin is really important around neurons to increase the speed of the conduction of nerve impulses. But if there's MS or multiple sclerosis that breaks down the myelin or demyelinates, now you can't process things as quickly. There's the slowing of voluntary motor movement. There's the increase in reflex time. Things just slow down. The degenerative changes to vision, to hearing, to seeing, to smell, touch, taste, and balance all go off. Balance especially. On the senior citizens that I take care of, it's the first thing I do is I watch how they sit in the chair and how they get off from a chair. If they can't get off the chair without using, like some people have to use their hands to stand up, horrible, shouldn't be. They should be able to just use the strength of their quads and hamstrings to stand. They have to be able to walk, turn around, and come back. 5 feet, that's it. Walk, turn around, and come back. If they can't turn around smoothly and they're taking very, very small steps to turn, there's a problem. When an elder loses their balance and they fall, the prognosis is not good. And typically within 2 to 3 months, their life comes to an end. It's usually associated with losing the balance, brain function, and heart function. They all go together. In terms of brain injuries, there are concussions, which are a temporary loss of consciousness. There's a contusion, which is a bruising of the brain. There's a laceration, which is a tearing of the brain from, let's say, a fracture of the skull or a bullet. And there are other causes of damage, like we talked about hydrocephalus, which is an increase in intracranial pressure, infections of the brain. And then free radical damage after ischemia. If there's decreased blood supply, very, very bad to the brain. Okay, let me stop my screen share here and stop the recording.